This is Darren Carell. This video goes over the most common management decisions that arise in patients using a PCA. It assumes that you have watched or already know the information covered in the Querying the PCA video, where we went over the why and how of getting data from the PCA pump. Now that we have all the information available from the pump, the management decisions that can be addressed are: is the patient using the PCA effectively? What can be done based on the answer? Do changes need to be made to the PCA? If so, what? And what dose of opioid should be used to make the conversion to enteral opioids when it's time to switch? I'll cover many of the situations that arise, but obviously not every contingency can possibly be foreseen and/or covered in this talk. But hopefully having an understanding of the most common scenarios will allow you to know what to do in situations that vary from what's discussed. One assumption for this talk is that the patient is either in pain and/or expected to have some degree of pain going forward. If the issue is that the pain has abated and/or the patient is overly sedated, knowing what to do is hopefully not complicated. Reduce the amount they can give themselves or stop the PCA altogether, and everyone will be elated. Sorry, couldn't resist finishing the rhyme. Another assumption critical to this discussion is that the patient is not someone with a known substance use disorder or with risks of opioid misuse. These populations will be discussed in other videos. The final assumption is that the patient is already getting multimodal analgesia using non-opioid and non-pharmacologic methods, so that opioid sparing is maximized and they need as much opioid as they're getting or trying to get. The first management decisions we'll talk about are how to determine if the patient is using the PCA effectively and decide what to do based on the answer. If they're not, then what? And if they are, do changes need to be made to the PCA? Now, remember, based on the lockout interval, you can determine how many times a patient can give themselves a dose every hour. For instance, if the lockout is 6 minutes, they can get 10 doses an hour. If the lockout is 10 minutes, they can get 6 doses an hour, and so on. We'll use a 6-minute lockout for the rest of the discussion, so the patient is able to get up to 10 doses per hour. Then, by looking at the various time periods in the 24-hour mode, you can see how many times the patient has been getting a dose delivered and compare this to the number that they could give themselves. In addition, look how much they've been pushing the button in relation to the number of deliveries they're receiving. There's basically two scenarios here. One where the deliveries and attempts are the same. They don't actually have to be exact, just within a push or two per hour on average. And the other where the attempts are consistently much more than the delivered doses over time. There's actually one more interesting scenario that occurs every now and then, and that's when the attempts are exactly twice the deliveries consistently over all time periods. To determine for certain what's happening, ask the patient to give themselves a dose. What you will likely see is that they double-click the button, as is common when using a computer mouse. So for me, these people fall in the attempts equals deliveries categories. It's just a function of technology programming us that is causing the attempts to be so high. If the patient is averaging very few deliveries per hour and pushing the button about as much as they're getting a dose, they are not using the PCA very effectively, since they're shortchanging themselves quite a bit. You need to ask them why they have been pushing it so little. If it's that they forget, they don't know what it is, they don't want to use it out of fear or for really no good reason, then you need to educate appropriately and encourage them to increase their use. If they aren't using it because when they do, it doesn't help very much or at all, and/or if it causes them intolerable side effects like nausea, vomiting, itching, sedation, then some change to the pump needs to be made. The next scenario is the patient who is averaging very few deliveries per hour, but pushing the button way more than they're getting a dose. Again, they are not using the PCA very effectively. The most likely scenario here is that the PCA helps when they get a dose, and they aren't having bad side effects. They just need to be re-educated on the lockout time. If the patient is averaging about half the deliveries per hour that they could get, and pushing the button way more than they're getting a dose, they are also not using the PCA very effectively. Here, it's possibly they are basically the same as the last scenario. The PCA helps when they get a dose, and they aren't having bad side effects. It's just by luck that they're getting more doses than the other group. So similarly, they need to be re-educated on the lockout interval. Another possibility, however, is that the benefit from the PCA is suboptimal when they use it. They keep trying it in spurts, but then give up on it for long periods of time because they're frustrated that it isn't helping enough. In this case, some change to the pump is needed. For the patient averaging about half the deliveries per hour that they could get, but pushing the button about as much as they're getting a dose, they are using the PCA reasonably well, but just not as effectively as they could. It is likely that the PCA helps when they get a dose and they aren't having bad side effects. Also, they likely understand how to use the PCA, they just straight up forget to use it too often. Having them literally stare at the clock to know when they can use the PCA isn't a good suggestion. But one thing I tell patients that's less aggressive is to have the TV on, and anytime a commercial comes on, or anytime someone comes in their room, they should actively think if they need a PCA dose. Obviously, if their pain is controlled, they shouldn't just push it to push it, but this gives them a decent number of times per hour where they can think about and remember to use the PCA if they need it. For the patient getting close to the number of deliveries per hour that they could, and pushing the button about as much as they're getting a dose, they're using the PCA as effectively as they can. Note, it's next to impossible to ever actually get every dose per hour. In this scenario, some change to the PCA is necessary. The last scenario is the patient who is getting close to the number of deliveries per hour that they could, but pushing the button way more than they're getting a dose. They're attempting to use the PCA effectively and hoping it will somehow work better if they keep pushing. It's definitely the PCA that's at fault here, and a change needs to be made. Obviously, the most important next management decision that flows from what we just discussed is what changes need to be made to the PCA in the scenarios where it's determined that the issue isn't just that the patient needs encouragement or education. We'll start with the patient not pushing the button very much because they're having side effects that make them not want to use it. First, you need to determine if the side effects are nuisance, like nausea, vomiting, or pruritus, or more serious, like dizziness or sedation. If they're nuisance, find out if the patient is using the antiemetics or antipyretic. If not, then obviously they need to give this a try. If they have tried them but they aren't working, then this points to the opioid being not the right one for them, and it's time to change to something else. Ask if they know what has worked better for them in the past instead of reinventing the wheel. If they're experiencing more serious side effects, there really is just one option. The opioid has to be changed, because if not, these side effects could lead to significant harm, including respiratory depression. Now we'll talk about the 4 scenarios where the patient has suboptimal pain control, and we've determined that some change to the pump is needed. The first thing we need to know is if the patient is getting any relief at all. Even if it's a little, that doesn't last very long. If the answer is yes, then the change that needs to be made is likely going to be straightforward. If the answer is no, then we have to ask follow-up questions and determine if the patient has used the particular opioid in the past. And if so, did it control their pain at the time, which obviously can result in 3 responses. We'll start with a patient who gets at least some relief from pushing the button. In this case, it's likely that the opioid is, quote, right for the patient, meaning that they seem to have the opioid receptor subtype that responds to the given opioid, and the reason they continue to have pain is a matter of dose. There's 2 ways to increase the amount of med the patient can get per hour. Make it so they can get more of the dose they're already getting, or more commonly increase the dose. Despite no data showing that a particular lockout interval is better or worse if you're within the 6 to 10 minute range, it seems to make sense that going from 10 to 6 minutes to increase the possible number of doses per hour from 6 doses to 10 doses might be helpful. However, if the issue is that they get some but not enough relief from using a dose, then generally the best option is to go up on the dose. The recommended changes based on the specific opioid are covered in the PCA Basics of Use video. One final option is if there has already been a few attempts to increase the dose and the patient continues to have suboptimal pain control, it's probably time to give up on that particular opioid and switch to another in the hopes it will work better. Now for the patient who gets no relief from pushing the button. If they've used a particular opioid before and they know it worked in the past, it should be able to work now. And just like the prior discussion, the issue is a matter of dose. So options are decrease lockout or more likely increase bolus dose. If the patient has never used the opioid before or can't recall if it worked in the past, the possible options for what to do are exactly the same as what we've been discussing. The difference is the switch to a different agent should likely occur a bit sooner than in the other scenarios, since we don't have anything that allows us to assume the opioid choice should work. Specifically, they have no knowledge it has in the past, and it hasn't worked even a little bit yet. The final scenario is that the opioid being used is one that the patient has used before and knows that it didn't work. Hopefully, it's obvious what needs to happen here. And the biggest conundrum should be why it wasn't known beforehand and the opioid never chosen in the first place. 2 other scenarios that point to changes needing to be made to the PCA are if the patient has been receiving frequent rescue doses, it likely points to the need to go up on the amount that they can give themselves. Again, either by lowering the lockout interval if it's longer than usual, or more likely going up on the patient bolus dose. I don't like to excessively restate things from other videos, but this next point is very important. In the very, very rare cases where an opioid-naive patient has a continuous rate, if they're starting to have more serious side effects and/or if they're not pushing the button very much or at all, it's time to decrease or discontinue the basal rate. The final management decision comes when it's time to switch to enteral opioids, and entails determining what dose of opioid should be used to make the conversion. How to actually do the conversion is covered in another video, as well as in a document and a couple of links on the prescribing guidelines page of the clinical resource section of the website. It may seem that this is as simple as looking at the use over 24 hours and using that as the value to do the conversion. Sometimes this is correct, but unfortunately not always. You do want to see the patient's use over the last 24 hours, but you should also look at the last 12 hours, 8 hours, 4 hours, and even 2 hours. The trends that emerge determine what dose of opioid should be used to do the conversion to enteral. As stated at the outset, every possible scenario can't be covered, but hopefully going over the most common scenarios will help guide you to think about this overall. In the best of all worlds, the patient will have adequate analgesia before the conversion so that the information gleaned from the pump is, quote, accurate and most useful. If they aren't so comfortable, but are ready to switch to enteral opioids, there's two tacks that can be made. One would be to adjust the PCA and let them continue to use it for some period of time to get more comfortable, and then base the conversion on that amount of opioid. The second would be to use the presently available information from the PCA to make the switch, despite it being suboptimal, with the hope that the change to enteral opioids will provide improved pain control given its better pharmacokinetic profile. There is no way to absolutely predict which option is best. Clinical judgment will be needed each time. For the examples, we'll use a scenario where the patient has been on a hydromorphone PCA for at least 24 hours and their pain is adequately controlled at the time of our evaluation. The first patient received 8.2 milligrams in the last 24 hours, 4.2 milligrams over the last 12 hours, a 24-hour equivalent of 8.4 milligrams, 2.7 milligrams over 8 hours, an 8.1 milligram 24-hour equivalent, 1.3 milligrams over the last 4 hours, or 7.8 milligrams in a theoretic 24 hours, and finally 0.7 milligrams over the last 2 hours, an 8.4 milligram 24-hour equivalent. So, this patient has had consistent use of opioid over the past 24 hours, and thus a reasonable dose to use for the enteral conversion is 8 milligrams, which was basically the actual 24-hour dose in this case. This next patient received 14.4 milligrams over 24 hours, 6.8 milligrams over 12 hours, a 13.6 milligram 24-hour equivalent, 2.8 milligrams over 8 hours, an 8.4 milligram equivalent, 1.4 milligrams over 4 hours, also an 8.4 milligram equivalent, and finally 0.7 milligrams over the last 2 hours, another 8.4 milligram 24-hour equivalent. This patient had a significant decrease in their opioid use somewhere between 12 and 8 hours ago, and then used a consistent amount over the last 8 hours. Obviously, something occurred that improved the pain or the pain generator decreased. In any event, a reasonable dose to use for the enteral conversion at this point is 8 milligrams, quite a bit less than the actual 24-hour dose in this case. This next patient received 5.2 milligrams in 24 hours, 4.3 milligrams over 12 hours, or 8.6 in 24, 2.7 milligrams over 8 hours, 8.1 milligrams in 24, 1.4 milligrams over 4 hours, an 8.4 milligram equivalent, and 0.7 milligrams over the last 2 hours, again an 8.4 milligram 24-hour equivalent. This patient had a significant increase in their opioid use somewhere between 12 and 24 hours ago, and then stabilized over the last 24 hours. Here it appears that something occurred that increased their pain a number of hours ago. Same as the above two patients, a reasonable dose to use for the enteral conversion would be 8 milligrams. In this case, more than the actual 24-hour dose. So, as you see, if we had just used the actual 24-hour dose to do the conversion, it would have only been appropriate in the first patient, way too much in the second, and too little in the third. Again, I can't cover every contingency, but I do want to end the discussion with two other quick examples of scenarios that come up frequently. I've just listed the 24-hour equivalent doses for speed of review. This person used equivalents of 10, 9.4, 9.6, 9.2, and then most recently down to 5.4 milligrams. Here, there's a big drop in use over just the last few hours. This could be because the pain has significantly improved recently and will remain so, or it could be that some unrelated factor happened that the patient didn't get to use the PCA much, but the pain isn't really abating yet. You have to have a conversation with the patient to get a sense as to what's actually going on. You don't necessarily want to base things on just a couple of hours of use, which is why we haven't been looking at the 1 hour time period. So the dose for the conversion may end up being around 5 or as much as 10 milligrams, obviously a big difference. This patient's use pattern was 6.2 milligrams over 24 hours, 8.6 milligrams per 24-hour equivalent over 12 hours, 4.4 milligram equivalent over 8, 6 milligram over 4, and finally 3.6 milligram 24-hour equivalent over the last 2 hours. For this last patient, use has been all over the place. Thus, the only way to even begin to decide on a reasonable dose to use for enteral conversion is to talk with the patient and dig into what's been going on over the last 24 hours. I hope you've learned something from this talk. Please look for the other presentations in the various series on the website. And as always, thanks for watching.